Are there in-office stain removal and or whitening procedures that do not involve peroxide or can get deeper into the enamel? Well, there certainly are, and they can be effective, but they might present risks that you may want to consider. Alongside Tammy, I'm Dr. Rob, and you're listening to the Dental Formulators Playbook.
So in episode 8, we discussed efficacy of an OTC toothpaste that contains 5% hydrogen peroxide, which was effective but risky. Realizing peroxide-based whitening can still be painful or limited in the types of stain removal. What else can be done?
Yeah, all of that is true, right? It was effective, that 5% hydrogen peroxide, but the risks involved the penetration, right, of the peroxide deeper into the tooth that could potentially cause inflammatory responses, right? Again, some people may have that response, some people may not, but that's where the risk comes in. But also some people said that it just felt like their mouth was just on fire, on fire. I mean, not for sensitivities anyway. So all of this is driving other options. And yeah, we need to talk about that. So peroxides, as we already know, they're really great for extrinsic stains, right? Those are the stains that again are trapped in the pellicle. It's that protein-rich layer that sits on the enamel. And the double bonds of all of those chromogens, the polyphenols and stuff, they're subject to the peroxide's action. That can get busted up. Even some of the protein, actually, by virtue of the peroxide, that can degrade a bit. And of course, if you couple in some abrasives, it can be really, really powerful, right? But, what if you have certain spots in the teeth and you don't want it to take forever to get those spots removed? What if, I'm trying to think, maybe you just have some superficial defects, maybe a little bit of light fluorosis, maybe just a little bit. Maybe you have, I don't know, maybe it's after orthodontia wear, where you actually have some unsightly spots due to the wearing of the brackets that cause some demineralization. Is there a way to quickly address those? And the answer to that is
There are other in-office therapies, right?
yeah,
Besides peroxide-based that manage whitening?
yeah, and this is one of them. And it's a little bit more invasive. It may require some tooth loss. Just a bit.
Great.
Just a bit.
So, is it allowed and is that normal?
Yes, of course. But, as with anything, buyer beware, man, because the patient likely doesn't know. And the dentist is going to be very reassuring, right? And honestly, the clinician is trying to do a good job. They really are. Whether it's an orthodontist, your general dentist, any kind of specialist, they're really trying to do a good job for the most part. Everybody's had that dentist that's a little suspect, but they're using their best efforts, right? Everybody's oral biology is different.
Hmm.
Everybody's. I mean, we know people that have never had a cavity in their life.
That eat
And it doesn't
horribly.
it doesn't even matter what the diet is. How is that even possible? It's just because everybody's oral biology is different. Dietary factors certainly come into it. And even though they may not have had a cavity, will they eventually have sensitivity? Yes. Or maybe I should say, will they have erosion, meaning the thinning of enamel due to, I don't know, for instance, drinking wine or
Hmm.
drinking, soda or whatever? It can happen. So, yes, for perspective purposes, okay, I know I just talked about enamel is going to be lost.
Buyer
I
beware.
know, buyer beware. I know this.
Educate us.
Yeah, this this is a little bit crazy. From a perspective of a normal dental prophylaxis cleaning, where the hygienist or the dentist takes the prophy cup, they take their paste, and they're doing all that circular grinding on the
Hmm.
teeth to help clean. What they're doing is they are removing that pellicle for you. Of course, any plaque that might have been sitting on top of that, the pellicle, and then they're trying to get maybe some of the superficial layers of the intrinsic stains that might just be on the teeth.
Okay.
This is normal. That typically results in a very small amount of enamel loss. Okay. Maybe 0.2%. And so maybe it's
Okay.
about 2 microns if somebody wants to know roughly what that is.
That doesn't sound as
If
bad.
somebody never had teeth whitening or they don't really participate in excellent hygiene, and they have a diet rich in polyphenols, things that are very colorful. So they eat lots of, I don't know, colorful, I don't know, grapes would be a great
They
example
drink
of that.
wine.
They drink wine. They can have a lot of different candies, right? You can have, even vegetables can do it. Anyway, it just can happen if you drink tea, you drink coffee, all these other things that can lead to it. If they just got their teeth cleaned, boom, it would automatically appear whiter. So sometimes just getting a dental prophylaxis alone, just getting your teeth clean is going to be fine because your teeth will appear whiter. But that's usually not what anybody wants, is it?
Okay. So, no. So, getting your teeth clean helps with some extrinsic stain removal and maybe a tiny fraction of
That's right.
superficial
That's right.
intrinsic stains within the outermost layers of the enamel. They're saying that's at best.
At best, right. Now, for
Okay.
other types of intrinsic staining or discoloration, such as what we just talked about, maybe some spots forming around orthodontic brackets during the time of wearing orthodontia, then
Mm-hmm.
there's another treatment that might be the option.
What is it?
That's the one that involves a little bit of enamel loss.
Oh,
It's called microabrasion.
microabrasion.
Yes, and this is the physical removal of enamel. Now, originally it was up to 200 microns
That's a
of
lot.
enamel. I know we just talked about 2 microns from a normal cleaning. Now we go from 2 to 200. It's 100 times more. Is that a big deal?
It's like 20% tooth
Well,
loss,
I
nail
I know it
loss.
is. It's about 20% of the enamel thickness. It's done with a concentrated acidic solution, usually hydrochloric acid, maybe phosphoric acid. It may or may not have some of these tiny abrasive particles like silicon carbide to help make that procedure done a little bit, I don't know, maybe more effective. And it's usually combined with like a Profi bristle cup, and it's with the slow rotation, no more than 500 RPM on the tooth. It's supposed to be gentle because you're trying to etch it away, and it can work.
That sounds awful.
But again, this can be used, especially if, different professional whitening approaches can't work. And I'm not talking about the in-office stuff where you have the lights, right? You go to make the dentist, you have a 35% gel treatment, and then you have the light on
Okay,
top
so
of
it's
it
all
in
different.
the chair. This is all different. We're talking because it's all that all still falls under peroxide,
Okay.
right? You can shine light on the teeth all day if you don't have peroxide. I don't know what you're doing. Are you just suntanning your teeth? I guess I don't know. Like you're just wasting. Actually, you're just giving the dentist money or whatever. The hygienist, who knows?
What I feel like half the time.
But
Anyway,
the point is, the peroxide is doing all the work. So we're not talking
other
about
stuff
we're
right now.
talking about other stuff, and
Okay.
so this microabrasion can certainly be used if these other peroxide-based approaches are not being effective for you.
Okay. So does it work on all kinds of teeth discolorations?
Well, theoretically, yes. Should it be? No. So there's going to be for people, a lot more people that probably are not going to be a candidate for this. So, for instance, if your
Even
teeth,
for removing 20% of your
yeah,
enamel.
that's right.
Okay.
So,
Just
so if you're,
stuck
I
with me a little
know,
bit.
I know, and it's good, and we need to be aware of this because although maybe 20% of your enamel might not always be removed, maybe it's 10%, maybe it's 5%. There are
How many times can you do
there
that?
are well, you have to be careful, right? Because you only have so much enamel, and it's going to depend, right? So all of these factors, this works into well, who's a candidate and who's not a candidate, right?
Okay.
So,
Right.
so for those people that already have thin enamel, for whatever reason, too many Jolly
Me.
Ranchers,
Right.
who knows, whatever it is, soda or whatever else, you're not going to be a candidate. Sorry, if you're going to be a bit older, longer in the tooth, you're probably not going to be a candidate. Again, if you have any kind of decay that had already been worked through with the restoration, you're not going to be a candidate, right? Your next thing, if you already had restorations, is probably a replacement of that tooth, whether it's an implant or some kind of veneer. If you don't want to have, if the
Mhm.
tooth is still salvageable and you just need it protected and capped,
Right.
that's,
Okay.
that could always be done. If you have some severe imperfecta, some kind of spots that just penetrate just too deeply into the enamel, maybe even extend into the dentin. And this also includes, for instance, any kind of post-endodontic damage that can occur. Maybe, if you can see your dentin, if you can see the underlying dentin, or you can see part of the root, or you can see part of the process and whatever was done, you're not going to be a candidate.
Yeah, that's probably not good.
Yeah, you're not going to be a candidate. If the tetracycline staining has been too deep throughout the tooth, you're not going to be a candidate. Again, if the fluorosis goes all the way through the enamel, you're not going to be a candidate.
Okay, so we know who's not a candidate. Who is a candidate then?
Yeah, so
Sounds like
those
a lot of people that probably aren't a
that probably
candidate.
aren't a candidate, but this is important because there's a huge market out there for this. Huge, massive.
Well,
It's for
yeah,
those,
people want their teeth white.
yeah, and it's for those that have the thickest enamel. So who do you think
Okay,
has the thickest enamel?
younger people.
Younger people do. So these are the people that might have Either orthodontia. Maybe they've had some white spot lesions, again, reversible lesions. They don't extend into the dentin and they're not too deep into the enamel. That usually a fluoride therapy and some other just patience, your saliva will remineralize and get it back
Mhm.
time. They would be candidates if you have shallow hypomineralization or hypermineralization, fluorosis, or any kind of other staining. If it's shallow, meaning is it less than 50 microns or 100 microns into your enamel?
And definitely not getting into dentin.
And dent, yeah, definitely not getting into dentin. Then you're going to be a candidate for that.
Okay. So regarding the white spot lesions, especially for those, of course, that have orthodontia,
Yeah.
uh, don't those you just said those can remineralize
Yeah,
naturally.
absolutely they can, but certain topical products can expedite this still. For those patients or clinicians, I'm talking about orthodontists too, orthodontist or, general dentist, everybody, you get into it. You want nice teeth. You want perfect
Well, you
teeth.
just have
You
braces on your
don't
teeth for how long?
exactly and whenever those braces come off, your teeth look nasty. They
Ugh.
just do. Now, the dentist or orthodontist, whenever they remove the brackets, there's usually some adhesive there anyway. So that can be burred off, that could be etched off. That's automatically going to cover some of the enamel loss, right?
Okay.
But if there's still additional spots that are still there and it just doesn't look right. I mean, what is a parent going to do with their kid seeing, hey, you got you want to celebrate, right? You just
Yeah,
got
when you
your
get braces, if you see
yeah, and all of a
anything,
sudden it's like, wow, look at all these spots. What the heck can I do? Well, that's why this microabrasion technique is really great at that because again, this originated in the 80s. Come on, orthodontia started getting popular.
hmm
They were trying to take care of some other, defects in the teeth, shallow defects in the teeth, and it was a nice option instead of, going to the next level and getting veneers or getting, some kind of implant or something. I don't know.
hmm
Like this was the next best thing, and it just predated the hydrogen peroxide. So again, it's not like there was a lot of options available anyway,
Okay.
right?
Okay.
So in the 90s, maybe some of the OTC trays came out and you could do that at home. But until then, and before then, and even still, you needed to get the higher prescription strength peroxide to really have that kind of benefit. What else are you going to do, right? You're the orthodontist. You want to show the parent or even the patient
Mhm.
itself, hey, look how beautifully straight your teeth are. They're not thinking about
They're
straight.
like, they're awful.
Even if somebody has perfectly straight, heck, even if somebody has perfectly white teeth, they think their teeth aren't white enough.
Oh my God.
I remember hearing a story of somebody who they actually used bleach. They actually used bleach, not just peroxide, but actually bleach to try to whiten their teeth. And the teeth were super white. But then also the whole gum tissue and the
Oh
cheeks, they
God.
were so also washed out. It wasn't good, but the teeth were white.
Well, it probably
But
ate
that's
away all the stuff in the inside of the
well,
mouth.
it's just not good, right? I mean, the cells don't like bleach, right? That's why, I mean,
That's
there's
why
not
they
much that
use
do
it.
like, if you have a bleach treatment, you do a kill time studies on microorganisms, you're going to get like a 99.99999%,
Right.
right?
Right. Okay.
Again, if you want to get rid of a body, you use bleach, right? There's a
That's what
reason
I
for
was
that.
thinking about when you said hydrochloric acid.
Yes,
I was like,
that's what you're doing. So
okay.
anyway, so we got to come back. So
That's another podcast.
yeah, talking about teeth here. So if you have stuff, some nasty discolorations or just
And you
some
don't want to be patient.
grayness, you don't want to be patient. Maybe it's grayness, maybe there's some other colors, and honestly, it could happen. Maybe you didn't take great care of your teeth during orthodontia. You didn't use a water pick. You didn't, use a
Mhm.
5,000 ppm toothpaste, which should be recommended for those
Required for
or
all with
required.
orthodontia.
It blows my mind that, oh yeah, you could just use over the counter. Well, with all those
Like,
plaque traps, that introduces something else. But anyway, there's some opportunities that where microabrasion could be used.
okay.
So,
So people are opting to
yep,
remove what would be otherwise reversible demineralization.
yep.
I would imagine that, of course, companies are going to want to exploit this, right? People
Oh,
are vain. They're going to
abs-
want to play on that vanity.
yeah, and they do, and certain companies will just dive right into this, okay? And it's still popular. In fact, with the latest products, we'll talk about one, but I'm going to talk about another one that really just captured this. And they said, wait a minute, what are the dentists doing? They're doing these microabrasion techniques. I think we could position our product as, just kind of insert that right into that procedure. So You have heard of this company, GC America. You know, GC
Mm-hmm.
America is a fine company. They make a lot of great dental products. You know, they're based out of Japan, but they have one product that is questionable, right? And
Heard about it over the years.
this is this MI paste product. It contains a specific type of calcium phosphate derived from milk. It's called CPP-ACP. There are two versions, you know, one with, one without fluoride. And it was always promoted heavily for remineralization, you know. But I mean, I think the active percent level is huge. I think it was like 10%, 10% of the of the active. And it really never really got better than fluoride. And I think it wasn't ever anyway, but that's a whole nother story. Anyway, even if it did work reasonably well for remineralizing, and again, for some people, it might be great. You know, for others that really need a good fluoride therapy, yeah, this product is not for you. If you have hyposalivation and you just don't have a lot of saliva that's generating calcium phosphate, maybe that product would be for you. Maybe, right? But because there's some other things and there's other things to be considering. But they got clever, their department, and they soon began marketing this paste not just as a nightly cream or a toothpaste that you could use and in replace or even in you know, of your existing toothpaste, they started saying, well, maybe this could be used as part of this microabrasion technique.
But microabrasion only occurs in the dental office, correct?
Yeah, and this was also being done in the dental office. So this was a prescription-based product. And so they were still going to the dentist and saying, dentist, this is what you need to, you know, have your patients use. You need to do this first in the dental office, and then the patient can take home, and then they could just use the product as they would normally do.
Okay.
Okay.
Yeah.
So, so what would happen is, you know, obviously, let's take a patient, a young patient that had orthodontia, had the brackets removed, unsightly spots. No, get them out.
Right.
What do you do? You first etch,
Which
and
is
they
what they would do
suggest
anyway, right?
which they would do anyway, but they would do a 1 minute long minimum etch with 37% phosphoric acid. 1
Yikes.
minute long, and then they would take photos of the resultant tooth structure, but not right after the etch. It was after they had applied the cream, this product, this, you know, this MI paste, and they'd say, look at how great the teeth look.
So there's no
So,
between the etching and the applying
right, exactly.
because we've already established that etching can already get
Yes,
rid of those spots.
yes,
Okay. Okay.
okay,
I'm following the bouncing ball.
yes. So, you know, the question that you have to ask is, well, how much enamel was lost?
Well, I'm assuming that enamel is lost. And
Yes.
so is there any way that we know how much?
Yeah, so generally speaking, higher phosphoric acid concentration, say something more than 27%, and it's typically used, what, 37% in doing these procedures. You're gonna,
Scary.
the average is about 30 microns if the etch is up to 30 seconds.
And they said a minute.
Yeah, with some people though, for that same 30 seconds, they can lose up to 170 microns. Okay. So that's like something like
Wow.
more than like 15% of your enamel in just 30 seconds, depending on if, you know, whatever your oral biology is, how susceptible to your tooth structure is to demineralization, what that is. Now, even if it is 30 seconds and you're normal, let's say you fall under the category of normal, whatever that means, right? But you're within that distribution where maybe that only corresponds to maybe 3% of your enamel. That's
Okay.
not terrible, right? That's only for 30 seconds. If you do it for 1 minute, consider the fact that it's going to be maybe 6%. And consider the fact that this might be a repeated procedure, maybe frequently if you go to the dentist,
So they're
especially.
suggesting this is something that's
It could be
that
done.
okay. So that adds up if you do this over because you have to etch each
You
time,
have to
correct?
etch each time. And what if you use what?
So if you have peroxide treatments,
Or and you just live, right? And you live and you have things that maybe
well,
naturally
anything
erode
that
your enamel.
I was gonna say, as you age
Yes.
anyway, and you drink
Yes,
and
you
you eat,
eat
you
and you
get that
drink and you're just
erosion.
taking, yeah, all that should factor in. So
Okay.
I doubt someone would be a candidate for more than once for this treatment. If for no other reason, on the safe side, you don't want too much enamel etched away. You don't
Right.
know if you're one of those people that all of a sudden are going to have an issue, right? I mean, you just don't know. But more interestingly, what is usually not talked about. So the dentist and the hygienist, they all try to do their best and they try to, you know, use their device, their vacuum, they try to suck up, aspirate all of that acid from right where they put, they're never going to get 100%. Full
Right.
stop. They will never ever be able to get 100% of that acid. And because enamel is porous,
Yes.
it's just going to continue to trickle down. It's kind of like the study with the peroxide treatment. I mean, come on, they found that peroxide, even from a 5%, 4%, 3% hydrogen peroxide, penetrated deeper into the tooth and into the pulp chamber. So peroxides can do that.
Yeah, we're
Then
talking about
surely a demineralizing agent,
acid.
yes. And
Well,
so
acid is it's meant to eat away, so it's going to eat away and fall, eat
eat
away
away
and
and fall,
fall,
eat away
eat
and
away and
fall.
fall.
Well, yeah,
And it's already porous,
it
so
might reprecipitate, it might demineralize, there might be some different
right.
reactions going on, but a really neat paper was published in 2019 that looked at this and they looked at X-ray tomography and they looked at the distance from the enamel surface all the way down. It was beyond 1 millimeter. So now we're talking about into the dentin. They even went to the root almost.
Okay.
And they showed that if, and this was specific for those teeth that had orthodontic brackets. This was a lab study, so they didn't use this on anybody in particular, but they were trying to simulate those conditions.
Okay.
Okay, you have a tooth, we put the bracket on, we take out, we take off the bracket and we do some light removing, just
Mm.
burrs and stuff. Okay, no difference in the enamel. Like there was no steady loss throughout the enamel if you just physically remove that with your
Okay,
burr,
the microabrasion.
with the dental burr. If
Okay,
the
physical.
Yeah, just physical only. Now you start adding in a little bit of the acid and using microabrasion techniques, all of a sudden
Okay.
significantly more mineral was lost in the body of that tooth, extending all the way down into the junction. And it was done even if you did not have the burr assisting the etch, even if you just had the etch, it was no different because it talks to the etchant as being able to
The
penetrate
acid getting
deeper.
down in
I mean,
there.
it makes sense, it's common sense, but to actually have that data and look at that data, and you can actually see that again, they use an X-ray technique. So they looked at the density of the mineral that was, going from the enamel to the dentin into the root of the tooth. And
Wait, it got down to the root?
they didn't study it that far, just near into the pulp chain, like just
Okay,
starting to
so
get
it's
into
getting
it.
close.
Oh yeah, so it was getting close. So, and that actually overlaps. That's consistent with the conversation that I had with an oral surgeon. Oh, this was probably 10, 15 years ago. I went to him because I had an issue with the restoration that I had received 20 years prior,
Okay.
right? I was getting some weird
Just
inflammation, weird
recently,
abscess. Yeah, that's right.
like years later.
Yeah, and I told him, I said, I don't know what the heck's going on. Why do I have this decay? It was a decayed. It ended up getting in my root actually was decayed. And I said, how the heck is my root? I was getting an abscess. My root was I had to get a crown. I had to get endodontic
The
work.
outside of the tooth seemed fine.
Everything was fine. And this tooth already had a restoration. I mean, everything was fine. But he said, Rob, he goes, this is a common feature. You get your restoration. We're not even talking about microabrasion. We're talking about restorations now because they still use phosphoric acid oftentimes to prep the tooth for any kind
Hmm.
of restorative work. He said it's absolutely impossible to get all of that phosphoric acid or whatever etchant they used off of the tooth. And depending on your oral biology, the biology of that tooth, it can take that long. Not only can it penetrate, but it can also take that long to get into the root of your tooth and
Wow.
become a problem. I had an abscess and it was, resulted in in like a pocket of gum. I remember that. And then, endodontic work had to come. I had to get a root canal, but it wasn't because my diet was bad. This falls under the category of iatrogenic factors. Those factors that can just happen because a procedure is done. These are inadvertent, accidental, you know, off target effects that can result from any procedure. So in this particular case, that was part of the issue. They could not get, presumably because there was no impact. It was on one of my back teeth. I mean, there was no
Right.
reason to have that.
So
So
that's concerning, because all these people, I know that when they're in their 20s, they're not
yes,
thinking about, I don't know, 10, 20, 30
yeah,
years down the road.
right,
They're thinking, I
yep.
want my beautiful teeth.
You want your beautiful teeth.
But
That's
then
right.
you're saying this surgeon said it's fairly common or it's a
Yeah,
potential issue that
yeah, this
happens.
can happen. And so, and what are they going to say? They're going to say, oh, well, that teeth already had a restoration. So, of course, it's going to continue to die. Like, they don't know. And they're going to,
Right.
even if they did know, what are your options anyway? You do the best you can with what you got when you can.
Right.
So, if you need to arrest that decay with a restoration, then you do it,
Right.
you
That
know,
makes sense.
and you just see what goes on later. So again, we're not trying to demonize anything, but those are some of the risks. So anybody who says, "Oh, it's just a filling. Oh, it's just this," it is not just that. All these etchants, you have to think very carefully. And if you're a parent of of a child that has braces, or if you yourself have braces, or if you're a formulator, you're somebody in this business that's like, okay, wait a minute, this is really interesting. I didn't know that this was even a
It's
thing.
an issue.
Well, and this is an opportunity to get
Yes.
involved in creating better products, maybe even better
Absolutely.
procedures to try to mitigate some of this because this is very real. And where does this fall under? All of this is done for cosmetic purposes. Do you really have to have approval to etch the tooth for cosmetic purposes? No, you don't need to do that. Really, what's
That's
important,
scary.
well, it is, but really what's important, and the dentist might become, or orthodontist or whoever might be more interested if there's a code for reimbursement for your insurance. That they might say, oh, well, okay, well, if insurance covers it, then we'll do it. But insurance isn't going to cover it unless it's covering a specific product too. And so
Okay.
this is where it gets really interesting. And we already talked about the other product. We're going to
Hmm.
talk about another one here in just a moment. But, you know, I don't want to start, I don't want there to be a mass, we're not trying to create mass panic here, but we
No,
also
no.
want you to understand that, a lot of practitioners actually use self-etchant primers, and those don't penetrate nearly as much as just phosphoric acid does.
It's usually for the restoration,
Yes,
the needed work.
yes. So things have gotten better
Okay.
probably since I had that restoration since a long time ago. However, for these cosmetic based approaches, they're still using phosphoric acid concentrated.
And
Maybe they're using hydrochloric acid again. It's not that big of an issue, but the issue is you could lose a substantial amount of tooth
that's where
structure.
the concern is.
And that's what the concern is. Yeah. So, Ultradent, they make they just make a ton of great products. They were one of the first to get in on the microabrasion technique. I mean, they created a 6.6% hydrochloric acid product
And
with
it's
silicon
there's a need
carbide.
for it in the industry
And
and
there
a
is.
place for it.
Yeah, purists like to use that one. Everybody else, if they're using 37% phosphoric acid, like for those that are saying, hey, look, we can etch it and put this cream on and now your teeth look great. Or if you just want to yeah, anybody who's doing that, they're probably not thinking about the long-term
Yeah.
repercussions of how a 37% phosphoric acid could penetrate into the tooth. So for that reason, that makes me a little concerned. So even if we have clinicians practicing that are thinking about this. Maybe they're going to wave their hands. They could completely disagree with me. And, that's fine. One of my teeth was an example of that.
Mhm.
And there's published literature out there that shows that these are valid points that need to be,
And concerns.
concerned about. I mean, this isn't just made up stuff. This isn't a what if. This is very pragmatic,
Hmm.
very realistic.
So it's interesting because we're talking about products that take advantage, is the only way I can think to describe it. Take advantage of the effects that you can get with etching anyway. Throw on what they call their product or Wonder Gel or whatever it is, and then claim efficacy. But let's remember, from if I understand correctly, just using the acid,
Yep.
then that spot is gone, right?
Yes, absolutely. That is absolutely correct.
Without this magic
Yeah, without
potion,
without any other things. Although I'm going to talk about what I feel is
we
absolutely
needed.
critical. Yeah. So there are more than a few papers out there that actually detail very clearly how the tooth looks before and after etching, and
Okay.
they don't draw any attention to whatever products were used, to help stabilize the tooth structure or the
Effective
going.
etching.
They just say that, yeah.
Okay.
And there was one paper that I really liked in particular. I mean, they looked at 3 clinical case studies and they followed up after 20 years. So of course it was younger patients who had the thickest
Right.
enamel that received the treatment. And what's really interesting is that they showed those images, and you could visibly see that the younger teeth were in fact thicker. And then you look at them even 20 years later, and you can see that there is noticeable thinning anyway, just due to a lifetime of using those teeth
Right.
for eating and drinking and whatever else, right? So, I mean,
Okay.
it just happens. For the microabrasion technique, though, as it was originally pioneered, if you will, in the 80s, for it to work really well, because you are damaging the tooth,
Well, you're removing some of
you're
it.
removing some of it, they would always apply a 1.23% sodium fluoride gel,
which would be considered professional strength.
professional strength, and
Okay.
they did that to immediately stabilize that fresh enamel that was just exposed, that,
You said before, fluoride
softened.
can react with that tooth immediately to
Yeah,
help.
very quickly.
Okay.
And again, it's notable that they used a high concentration. They just want to make sure they're arresting and preventing any further demineralization,
Yeah.
maybe if there was some phosphoric acid, or they're counting on some of that gel, and they typically like to use a gel.
Okay.
And it was acidified gel, so it'd just be able to have,
Facilitated the
yeah,
fluoride
the
decay.
penetration in, deeper into the tooth. Yeah,
Okay.
that should go like that's like a handshake. Like you can't do the microabrasion technique unless you have this 1.23%
High fluoride.
fluoride.
It makes sense.
Yes.
But
But
you're gonna have these companies out there, right?
yes.
And everyone's screaming, "Oh,
Yes, exactly.
so this is where the opportunity exists for others to come in and recommend their product as a substitute for that,
As
right?
a substitute for that arresting very important part of that, adding the fluoride. Yes, that's what they did.
Okay.
GC America did that. I still have some advertisements. You should see what they say. I mean, some of them went even 2 minutes on the phosphoric acid etch. Oh yeah.
So they went
And
they
dude,
went
it
way
was, you have no
beyond.
idea. It was like a cycle of it. Some of them even went like 5 etchings. It's, and you're doing these,
Tooth left.
well, they do, but you know what? Whenever that person reaches the age of 40 or 50 or 60,
Wow.
and they're gonna maybe start having sensitivities. I
Oh,
mean,
yeah.
I just can't, anyway, but that's
Wow.
not us. And well, that's not the topic here. I mean, again, we're not trying to badmouth that product necessarily, the company, but definitely how they're positioning it. Absolutely. Because for me, that's false marketing. And you're causing a patient to have damage, whether they know it or not. So they boldly advertise that. We have examples. I could always share that, of course. I mean, it was public. I mean, that's what they were advertising in dentist's office. I mean, that's just what they were.
Right.
Anyway, they say that calcium phosphate helps remineralize structure. Yeah, no doubt it does, but what gets there faster? Fluoride. And what forms better acid resistant mineral?
Yeah.
Fluoride.
Then
You know,
calcium and phosphate, most
exactly.
definitely. So, but the etch is doing all the work. Let's be real,
Yep,
correct?
absolutely. Of
Okay. So basically, it removes the troublesome spot on the tooth. So, of course, it's going to look better.
course.
Choosing to ignore that the acid is doing all the work, but of course, I don't like it when you already know that the acid etching is doing the work because it's documented in several cases because it's for restorative or whatever purposes. But GC America says, "Hey, look, we got this really thing.
Yeah, this is awesome.
Let me
Yeah.
put it on there."
Yeah.
And it's so that's not cool. So
No.
that they've been around forever. Is there anybody else doing
And they're
this?
not doing that as much, by the way. So I think
Well,
that
maybe someone
maybe,
called put.
well, maybe somebody do some shade on it. Yeah, because it's just not good. Or maybe the results weren't that good. And maybe somebody
It
was having
does alone
sensitivity.
that the
I don't
results
know.
might be coming out.
Yeah, well, there's a new product that's doing this.
Oh,
It's called Curadont. I call it Curadont. They're not going to like that. I just don't care. I think it's a gimmick, but that's my view. And we're going to talk a little bit about that. It originated in Europe. Okay.
where there's less regulation
Where
than
there's less
here.
regulation. Yep.
Okay.
Product is still used by the dentist. So it's not like this is a product that the patient can take home. So it's not like a take home toothpaste. In that area, it varies a little bit different from GC America. So this is a really interesting case study, actually, because this product is accompanied by a procedure.
It's an in-office.
It's an in-office, yes, it's an in-office procedure
Okay.
again, but the patient doesn't get to go home with the product and use it,
Okay, so it
for
only
whatever
happens
else.
in the office.
Right. So before, what GC America do, they say, look how great the MI paste did with making this teeth look good, even though it was the etchant. They
Mhm.
would say, patient,
Take this
now you
product
could take
home.
this home and now you can use it because look at all this great stuff. Okay, yeah, false. The etchant did the work. You do need to stabilize your tooth. You should probably be using a fluoride toothpaste, not just the calcium phosphate one. But here, this is a little bit different. So this is one that this product contains an oligopeptide, which has 11 amino acids. Okay, they've been tethered together. It was engineered to say, hey, look, it can help remineralization. It can help attract calcium ions and phosphate ions, and it can help guide new mineral. Okay, the marketing story is good. In
Gotcha.
fact, the scientific story and the approach, I think that that's a good thing.
Okay.
But but it's listed as the inactive ingredient in the product.
So their oligopeptide,
Yep.
their miracle agent is not even listed as an active.
No, it's not inactive and it hasn't received NDA clearance, and we don't have any idea on the safety profile. We don't even know proper dosing. They don't even tell you the dosing of it. So,
Marketing claims that
oh
this is
yeah.
what's doing all the work.
Yeah, so that's what they're going to
Okay.
do. The product actually it comes in a two-part, kind of like a syringe, maybe even like a screw type, not just two separate, syringes, but you squeeze it together. One part of it is in a more alkaline environment, then you have another part that's more, acidic because it exists in a flowable structure in an alkaline environment, but that's not the structure you want for best remineralization. You want to have it under physiological pH, which is around 7. So you mix it together and then you apply it to the tooth.
Okay.
And we'll talk about the procedure here in just a minute. What is the active ingredient? You might want to ask then. If
Well,
you have a product, right, but the oligopeptide is not the
but
active
it's claiming
ingredient,
that it
but it
remineralizes.
claiming that it remineralizes, what do you think is the active ingredient?
Well, there's only one that does any remineralization, right?
That's right. And they do have an active ingredient listing on the box, and it
Okay.
is for anti-caries. So it must be
Okay.
fluoride, and it is. Strangely, though, this is what I can't get over. So we just talked about 1.23% sodium
They
fluoride.
use that in the 80s because they want to stabilize the
Yeah, you
tooth.
got to stabilize the tooth structure because you're still going to etch it. Okay. You're still going to etch it. Guess what the level of sodium fluoride is in this product? I have to laugh
So
because
this
you want to
product
know.
claims first etching, right?
Well, it will. Yeah, that's all part of the procedure,
Okay.
right? I'll
Before
talk
you put
about that.
product on.
Yeah, but what's the level of fluoride, do you think? Do you think it's 1.2?
Ethically, it should be.
Ethically, it should be. How about 0.05% sodium fluoride?
That's over the counter.
That's over the counter level.
This
Yes.
is being done only in the dentist
Only in
office.
the dentist office. So here's the full instructions. So
Okay.
2% sodium hypochlorite. Remember bleach that kills everything? So that can actually help remove with the pellicle. So now you're preparing the tooth, right? But that's not all. But wait, there's more.
Mm-mm.
Then for 20 seconds, you etch with 37% phosphoric acid. Then you then use this novel product with the two chambers, you mix it together, and you apply it to the said tooth.
Okay, so
This is all part of the procedure, by the way, on the box. Like this is all how to use. And
okay, so
any dentist that has ever done a microabrasion or prepped a tooth for a filling,
well, they know how to do
they
that.
know how to do it. They know what's going on.
Okay, so but they give specific instructions on the etching part.
Yes.
Like, okay, because that sounds pretty harsh, 37% phosphoric acid.
20 seconds.
Um,
Yeah, they might lose maybe 20 or 30 microns, maybe. Could be more depending on the biology of the tooth.
okay, and
So you better start with thick enamel.
they're not the dentist is timing it correctly when they put it on.
Oh, I know.
Okay. Then they follow it up with an over the counter product then, right?
That's right. 0.05%
So
sodium fluoride.
that's a very low level of fluoride that's applied to the now cleaned, etched, thinner tooth.
Yeah, and it's the only listed ingredient. And in my view, fluoride alone is a guided enamel remineralization technology. In fact, I think it's probably the first one. Maybe it's not talked about that. Maybe there's a scientist, maybe more than one, who want to play semantic games and say, well, we're guiding it. You're guiding it. You're not guiding it with this oligopeptide. I'm sorry. This is just not how it goes. And if you do believe in it that much, A, don't add fluoride, and B, get regulatory approval, use the
Mhm.
proper mechanisms here, do the proper homework, and then do it. Otherwise, this is just getting, a little bit, crazy. And we're not the only ones who think so, by the way. So most studies investigating this particular product, even outside of this, etchant, this microabrasion technique for white spots, they show that, geez, it works way better whenever you combine it with fluoride. Whether it's the amount of fluoride that's in a fluoride varnish or a toothpaste or something like that. Alone, go
Nothing.
fish. Go fish. And so
So they demonize fluoride
I,
to a degree.
oh
To
yeah,
a
well,
degree.
yeah,
And
and
then they're saying, but we have the miracle thing to do it, but our miracle thing doesn't work
yeah,
without
and
fluoride.
some other independent researchers, because that's what you also have to look at is the independent research. I'm not saying independent's the only way to go, but some of them may raise some questions, and they said,
Mhm.
look, This stuff is so viscous whenever you mix it together, it's just going to precipitate out or it's super difficult to work with. How do we know it's not going to actually interact with the tooth that it's supposed to? And maybe it's just reacting with itself and it's just sitting there and then it just gets washed away. Some
Wow.
studies have actually shown that.
Oh, wow.
So the fact that it is so very viscous makes sense, right? Because if you look, even if you look at their product instruction video, okay, and the patient, by the way, you're going to be sitting in the chair for a little bit because first you have to get prepped. You got to have the bleach on to get the pellicle off. Then you got to get your
Makes me
phosphoric
cringe.
etch, and then you got to get this treatment. And the viscosity is such that they give you a sponge applicator that the clinician has to kind of work into your tooth. It's not like this is a nice soft or free flowing gel that you could just put on your tooth and then it's good. No, they have to kind of apply some pressure.
They have to smush
Okay.
it in.
Yeah. And then they got to leave it like there for about 5 minutes and then maybe clean it off and then you can go do your stuff. So but your mouth in that whole time is just open, with the rubber dam and you can't swallow properly, right? All that stuff. So
Yeah.
it's but between the bleach and then the acid and then this treatment,
Wow.
it just seems like enough. When a true microabrasion technique, you also have some of that stuff, but at least you're going to have a more predictable outcome. Here, I just don't know about this. One of the other ingredients that they have, I told you that this comes in a two-part system, right? And one part is buffered that has the protein. Well, it has tris in there. The tris is the buffer. Tris is sometimes referred to as tromethamine, and that is exactly what is on the box in terms of the
Okay.
inactive ingredients. That's fine. You might think, okay, it's a nice buffer. It's a well-known buffer, of course, and it maybe is going to help with preservation and stability of the peptide and all that stuff. That's fine.
Okay.
In some ways, it's really similar to EDTA.
Or a decamil if you're live fresh.
That's right.
Sorry.
But it's been known to interfere with enzymes, and it also chelates metals, like,
EDTA or decamil.
yeah, and the metals would be calcium. So,
So,
just like there's issues of maybe calcium being pulled from the tooth, right? This could also have that same kind of effect.
when it's
Or
supposed to be putting it
when
in.
it's supposed to be putting it in. Again, I'm not really sure about its activity here. I think a really low level, 0.05%, is is just too low. Is just too low.
Okay, well, I'm still having a problem with an OTC product being administered in the dental office for a prescription price. And if you get repeated treatments,
Yeah.
the poor enamel is going to get thin really, really quickly because
Right.
they're not even using a high level of fluoride to help.
Well, right. But some insurances do cover this, by the way. So, they cover it because it's a procedure, and the restorative code is actually has been assigned to this for reimbursement. Now, the catch is, does your insurance cover this? Well, maybe. But then I have to ask, if this works so well, why is it be considered a restoration? So again, you have an OTC product,
Because they're doing it for cosmetic reasons,
an
correct?
OTC product. Yeah, but even a cosmetic, you don't have to get a restorative code for that. Like, there's probably other codes, but it's not restoration. Restoration means that you've had some invasive work. And this is all part of the
Okay.
microabrasion, If they want to couple that,
Okay.
then all of a sudden you can start getting coding the right way. So this is actually a form of restoration, even though really it's a microabrasion technique. They should be,
Hmm.
anyway, there are some nuances here, but at the very end, the etching of the undesirable spots is something that can be done, no doubt about it. If you have thick enamel, that's fine. But you have to worry about the phosphoric acid slow penetration, of course. That gives me pause. And the low level of fluoride is questionable.
Yeah,
Go ahead.
that
Yeah.
doesn't make any sense to me at
Yeah.
all.
Well, with the buffer being what it is and having those risks, you might think, is that all? But because this episode is, but wait, there's more. It's not all. They also use chlorhexidine gluconate, digluconate, I should say.
Hold on. Isn't that to control gingivitis?
Yeah, it is, and it's way more common outside the US. So, and you can't get a gingivitis
Okay.
claim on that. So they don't even try to claim that, but it is in the inactive ingredient panel. Usually it's limited here in these kind of products inside the mouth at about 0.12%.
Okay.
I don't know if that's the level that they're using. They don't specify. You can get higher strengths, like 2% or even more, but usually those are for like your hands or for cleaning a surface. You can get those if you're a dental office. Like, you just have to
Okay.
make sure that you have your licensing for that. But in the mouth, it's about 0.12. Now, here's some points to consider even if it had a potential antimicrobial benefit.
Hmm.
Well, first of all, this product is not natural, right? So even if they want to say that it's like enzymes and we have all this 104, all of a sudden we're using tris, not natural. We're using chlorhexidine digluconate, not natural. So, is this even a natural or a nature inspired kind of process to guide your enamel remineralization? No, it's not. So here's some issues with the chlorhexidine. First, it may cause staining.
Yeah. So that's what I want my tooth whitening product to contain, right?
Yeah,
That makes
exactly.
sense.
It may also cause tartar, but of course, both with the staining issue and both with the tartar, you know,
It's
it's usually with repetitive use, but
which
usually
they claim to
which
do.
they claim to do, and that's, sometimes how to mitigate any stainings. The clinician would even tell you, or even the manufacturer, they would say, okay, after you use a product, wash it out. Rinse your mouth out so that you can help reduce some of that staining. But if you just had your cereal and then you're supposed to let your tooth like just be okay for 30 minutes
Well,
before
not
you
even
eat or
that. They
drink,
just opened up the whole tooth with all the
I
extra.
know. Well, you're gonna have to rinse, and so that begs the question, did you just rinse off and wash away
What I
that
paid
very
for.
viscous substance that's just sitting on, and these are with the public facing teeth, right? This isn't being done necessarily in the back of the mouth. These are in your incisors, the stuff everybody sees, and that you have your whitening issue, right? So it's not like somebody's gonna say, "Oh, I don't care about a little staining here, or maybe there, maybe this,
Mhm.
maybe this." No, these are your forward-facing teeth. These are the teeth that are going to be thinned over the course of your life. They just will. That's just fact. You live a long life, that's the great reward. You're gonna have thinner teeth potentially. Again, depends on your biology, and you're gonna have recession of gums. It just happens that way.
Thinner teeth, thinner
Thinner
hair.
teeth, thinner hair, everything, right? So there you go.
Okay.
But so maybe some tartar, maybe some chlorhexidine, again, if it's being used quite a bit. But lastly, in 2017, the FDA issued an alert for increased guidance on use of topical chlorhexidine because there were adverse reactions. And this really started removing some of the other players in the field in the marketplace, who actually had chlorhexidine as one of their products. They were like, okay, well, if there's adverse reactions
Right.
and it's becoming more commonplace, and now we got to add additional disclaimers or we have to inform our patients on this, maybe this is something we don't want to use because it could
Logically.
cause a problem. And it's really interesting because there was a product that was really great. Well, I don't know if it was really great. I tell you what, it was an option for those with deep periodontal issues where you actually had deep pockets. It's hard to keep that clean. There was a product called Perio Chip that was introduced. That was also then pulled from the market in 2022.
So
Also,
I've never heard. What is perio chip?
so perio chip, so this was an interesting technology. It came out of Israel actually, and they filed for a new drug application and got approval from the FDA in 1996. And it was a chip that would slowly release 2.5 milligrams of chlorhexidine over a period of several months. And so maybe a patient would get replacement of these in their pockets where they actually had, the periodontal issue, and then maybe that's one way that they could get some kind of antimicrobial relief,
Okay.
right?
But it has since been discontinued. So all the effort that to get the FDA approval and it's no longer available. So do you think this is directly related to chlorhexidine?
Yeah, I think it's a combination of factors, isn't it usually, right? I think the FDA guidance in 2017 that said, hey, we're having some heightened awareness of this, that may have presented one of the issues. It's kind of like triclosan. It starts with like some adverse reactions.
Hmm.
Okay, now what's going on? All of a sudden, then it gets pulled, and now you can't get it in whether it's in hand soap or whether it's in toothpaste, right?
Right.
So this could be one of those scenarios. But the other scenario is, is it really, do you want to have staining? If you're having the slow release chlorhexidine, it's going to continue to stain, and you may have more tartar. And by the way, I don't know if
Okay.
you're really actually getting an overall better, oral hygiene
Right.
response from this. So I think all those factors probably went into this, you know?
Okay, so this curadont, sorry, contains chlorhexidine,
Yes.
which is basically a broad spectrum antimicrobial, right?
Yeah, that's right. It is. It's not, it's not necessarily biome friendly, it's meant to wipe out microbes. I mean
Everything.
that's just what it is. So and again, I think that between the combination of having low fluoride, you have chlorhexidine in there, you have a buffer that may actually attack enamel or may degrade enzymes, like the very thing that I know enzymes it does, and I know the oligopeptide isn't necessarily considered an enzyme, but enzymes are made of the same amino acids,
Right.
building blocks of proteins. So could it have an off-target effect? I
Absolutely.
don't know, but I have to think about that. I have to think about why it has a level of fluoride that's 25 times less than what is typically used in a microabrasion procedure with the 1.23%, you know, sodium fluoride. I just, for me, all of that, especially the OTC product for the prescription price, hoping that your insurance covers it, and you might have to go more than one procedure. To me, that's too much. Like I would say,
That's pretty crazy.
I would,
I still have a hard time getting over. Let me have a very low fluoride over the counter product that I put in your mouth, but oh, by the way, I want to charge you
but oh,
10.
by the way, I wanted to charge you top dollar. If you are a candidate for this process and you have a choice in the matter, whether you're a parent, whether you're a clinician, whether you're the patient, don't go for the cure. Don't say microabrasion, stabilize my tooth structure because I want
Use
the fluoride to react.
fluoride, thank you.
It's not like you have to use the fluoride at home all the time after you've done this. It just needs to be applied in that very instant. That is what, right in that instant. If you
Because
don't want to use it whenever you
it
go home,
reacts immediately.
don't. But clinicians, that would probably be the best thing. I know this is a late model approach. We're trying to get in everything's new in technology. I don't see it. I don't see it. And I would actually wonder, why are you putting in zero point zero 0.05? Did you do those studies? Why wasn't it zero point zero 0.02?
Do you ever
Why
think
wasn't
we
it?
can get to a point where it's an ethical argument if you do etch the teeth that you have to
Well,
put a certain amount of fluoride
I'm
in?
just saying it might be I think that usually this stuff comes about whenever adverse reactions occur to the point where all of a sudden lawsuits have to be
Yep.
introduced. And all of a sudden then people are going to be like, what are you doing?
Right.
Is this ethical? Just like any other ethical, topic there is about,
Absolutely.
forever chemicals or whatever else. I mean, at the time, maybe they know, maybe they don't. Oftentimes they do that there's going to be some damage. Are they going to rectify and all this other stuff? Well, who knows, right? It all depends on the company. But this product, they're not even based in the US, right? This is a company that I think the original technology came out of England, then it was licensed to yet another entity, then it was sold. Some rights of it were sold.
It's a money grab.
Different entities in Germany and Switzerland had an interest and still do. Yeah, I'm sure we're going to get a lot of shade, a lot of hate on this. I don't care because I just don't think it's been proven enough. I think it's unhealthy, it's unethical for the patient. I do. Stabilize the tooth structure. I mean, that's the most important point. In addition to the process, we're talking about the microabrasion. Again, we have to be super clear. The reason why the teeth looks as good as new is because it is new enamel, and it's because the etch worked. The etch removed the old or ugly or unsightly and presented new mineral that had never seen the light of day,
Mm-hmm.
that had never seen a mirror before,
Shiny and
that's
beautiful.
never seen a toothbrush before. That's right. That is what you're saying, and it's from the etchant. So if it were me getting the etchant, that's fine. Hit it with fluoride, quickly stabilize it, and have that fluorapatite mineral be formed.
Because
Get the stuff that's more
that's how
acid
it's
resistant.
resistant, of course. Because as you said, studies have shown over and over again that simply etching the teeth automatically makes the appearance better.
Oh yeah, I mean absolutely. It's all about that. So, and again, I'm not we're throwing shade at the products
Yes,
or their
absolutely.
positioning. We're not throwing shade on the microabrasion technique. I think it's a tool. I think it's a valuable tool that should be added to the toolbox of anybody trying to figure out, well, how do I get rid of some of this intrinsic staining? Because again, that's what this is about, right? The peroxide maybe he's not doing it, maybe he's not doing it as effectively. Here, there's an
Exactly.
option, you
Just do it
know, we
responsibly.
just need to do it responsibly. That's it. And, there's peroxide can soften the enamel. We know this, but if you have products that are responsibly made, like peroxide gels right now that have some fluoride in them, right? One of the reasons is because the peroxide's demineralizing that structure. Kind of has to sometimes if it's getting deeper into the tooth with these radicals, right? With these ions that are getting in there. Put fluoride in there, help stabilize that structure.
So these, like you
Yeah.
said, the newer ones are
Yeah.
coupling fluoride with this peroxide to help with both remineralization and stabilization.
Exactly. Yeah, that's the key.
So the demineralization. The white spot lesions will remineralize on their
Yeah,
own
we should definitely, yeah, if
if
given
given
time.
time
I
to do
know.
so.
Yeah, I mean,
If you have that
if
patience,
you have that
yes, if you
patience, I
don't.
think that's also important to say too,
Yeah.
see what can happen. But if you don't want to be patient with it, and sometimes the spots warrant intervention, like a microabrasion,
Sometimes
you
those are
know,
considered
they
watches and
just
stuff, right? And
well, they could be, it all
it
depends,
depends on the nature of them.
we're talking about mostly in the incisor tooth.
Okay.
If a dentist is going to call a watch on a tooth, usually that's one of your grinding, chewing
Okay.
teeth.
Makes sense.
You know what I mean? And those ones, it's a little bit, would you really etch it to make it look good? Probably not.
Okay.
If you
That
can
makes
get your
sense.
first upper four, six teeth,
Yep.
upper, lower, then you're doing pretty good. If you can get the whole mouth, that's good, but usually this is focused on just those forward facing,
Okay.
public facing teeth. But anyway, so if peroxide can't fix it, microabrasion can't do it, then you're going to be left with doing veneers or full restorations, implants, whatever. That's fine.
Okay. Yeah, but
But
that's outside the scope for this podcast.
absolutely, that's right. All right, so we discussed the next level approach, an invasive approach, but minimally invasive. I mean, you don't need Novocaine. They just etch it and they just do it. I mean, you're going to be okay. But we need to come back to the extrinsic stains, I think. And in the next episode, in episode 10, we're going to talk about non-peroxide alternatives that can come back and get to these extrinsic stains. Because although what we discussed today was probably very interesting and helpful, what about things like apple cider vinegar? What about using baking soda and all
Oh,
these other things?
yeah.
So that's what we'll cover in the next episode. So for now, this is Tammy. I'm Dr. Rob. You've been listening to the Dental Formulators Playbook. We look forward to the next episode with you.
Thank you for listening.
Bye bye.